Good afternoon. People are still joining. There are always those first 5 minutes can be tricky. So this is our second online event, and it's entitled "The Pivotal Role of Preclinical Brain Tumor Models in Improving Treatment Efficacy and MRI Monitoring." As an introduction, let me introduce myself. My name is Simões. I'm head of preclinical MRI at Arias in Portugal. And my colleague, Nuria Arias Ramos, is co-moderating the session with me from the Institutes of Biomedical Research in Madrid, Spain. We have two speakers, Vivi Zoteva from Clouds of Care, working at Clouds of Care in Belgium, who's going to talk us about optimized rat glioblastoma model for testing new MRI-guided treatments, and Paula Candiota from the Autonomous University of Barcelona in Spain, telling us about MRSI-monitored chemoimmunotherapy in mouse glioblastoma. So as people are still joining, I'll just do a quick overview of what GliMR is and where we stand. So GliMR started as a cost action between 2019 and 2024, which aimed at advancing the use of MRI for brain tumor diagnosis and treatment, namely glioma. It was very successful with extensive networking, leading to several position papers and multidisciplinary collaborations, leading in turn to successfully securing European funding, and others are still actively applying for it. And since last year, GliMR became a working group of the ESMRMB, European Society for Magnetic Resonance in Medicine and Biology, and spanning several task forces. So the Preclinical MRI Task Force is one of them, and the aim is to bridge that gap between preclinical and clinical MRI in the scope of glioma research. The idea being to make it truly translational between disease models and patients. As I said, this is the second online event this year after the virtual debate that we had in July, which tackled the role of preclinical MRI in differentiating between pseudo and true progression during glioma treatments. And as I already mentioned, today we have our two speakers, Vivi and Ana Paula, who will present their work on different immunocompetent rodent models of glioma, rats and mouse glioblastoma specifically, and the role in testing different chemoradiotherapy and chemoimmunotherapy treatments, and monitored by MR and anatomical imaging and metabolic imaging. So I don't know how many we are now. So we have 20 participants. I think more registered, but it's 5 minutes past 2. So Vivi, I think you can start, and the floor is yours.
Thank you. Thank you for the nice introduction. I will share my screen, and hopefully you can all see this. It should be, and also my pointer. Nod if you do. Okay, perfect. So I will be talking today about an optimized rat model for glioblastoma, where we can use this optimized model more as a guiding principle. So everyone would use the same standardized protocol. So I will guide you through the workflow of generating this animal model, and also give an example where this animal model then is used in a use case to test a new adjuvant treatment for glioblastoma. So first, a very short introduction. Glioblastoma, of course, everyone knows, remains a highly lethal brain tumor. This is due to several reasons, but the main ones, or it all comes down to a lack of effective therapies or adjuvant therapies due to tumor heterogeneity, therapy resistance, limited blood-brain barrier penetrance, and so on. The reason why effective adjuvant therapies are not successful yet is also, unfortunately, due to a poor translational success of preclinical findings. Now, I will be talking more specifically about the F98 glioblastoma rat model, which is a widely used animal model for glioblastoma research, but it still has some limitations, which I will highlight in the following slides. But all comes down to that we need a more reliable, reproducible, and translational relevant glioblastoma animal model. In preclinical research, MRI imaging is very essential to monitor glioblastoma growth and is actually used as a kind of surrogate biomarker for treatment response. So we can, with MRI, measure non-invasively longitudinal assessment of the growth of the tumor, the therapeutic efficacy, and of course also animal welfare. MRI is useful because we can characterize the heterogeneity of the tumor, the infiltration, edema, and in preclinical settings, we actually have a tool that is closely aligned with what is used in clinical practice, with higher resolution, of course, because of due to the smaller animals. So in this presentation, my goal is to show you how this model is optimized, to show you the workflow, as I mentioned, to test new adjuvant therapies in MRI-based studies, and then show you a practical example where this optimized animal model is used. So the clinical evaluation first, when we talk about optimizing an animal model, we have to go back to what is actually happening in the clinic. So for glioblastoma, we know the most conventional diagnosis and follow-up monitoring is based on gadolinium enhanced, so contrast enhanced T1 weighted MRI, T2 weighted MRI, and FLAIR imaging. And the standard treatment for glioblastoma is, as we know by Stubb et al. In 2005 already described, is surgical resection followed by fractionated radiotherapy, 30 fractions of 2 gray, giving a total dose of 60 gray, and a concomitant and adjuvant temozolomide chemotherapy. Of course, after the patient unfortunately has passed by, we usually confirm the tumor for real glioblastoma diagnosis by histological analysis. Now, we do have currently already techniques that enhance animal model translatability. So we have that tools, so for example, stereotactic frames and microinfusion pump that cause a precise tumor cell implantation, so we would obtain accurate and consistent tumors. And this is very important because actually we already see in 1980 by an author called Kobayashi that, for example, freehand injections cause in poor tumor growth, or just the tumor location is not consistent between animals, creating an unreliable and unreproducible animal model. Also, with the microinfusion pump, it's already been shown that you have to inject at least 100 cells in the animal to guarantee tumor development. Then the radiotherapies, we have image-guided small animal microirradiators. Here we see on the left side the SARP, or the more newer version. I think 1 year ago it came out. It's the Smart Plus. It's a more potent radiotherapy machine to deliver X-rays using kilovolt photons. So these machines make use of a CT image to guide the positioning of the beams, but also MRI, so you can localize your tumor and accurately position your beams. And at last, to monitor your tumor growth, it all depends on your research question, of course. We have MRI here on the right side, preclinical MRI, and others, such as here on the left side, I show the molecules, which are, for example, PET or SPECT, which can be used for small imaging of small animals. Now, what are the criteria for a good and a standardized animal model? First, we have, and this is obviously, it has to mimic the human glioblastoma as closely as possible, and this in terms of tumor microenvironment and growth characteristics. So this means, for example, the intratumoral heterogeneity, the neovascularization, the blood-brain barrier that has to be permeable, invasive growth pattern, and so on. This is, of course, very difficult as Sometimes you can use, of course, cell lines from human glioblastoma, but then you need immunocompromised animals. So it's a trade-off between using the right material and using, for example, a chemically induced animal model, but which is more easy, of course, to obtain, and you can use an immunocompetent animal. Next criteria is we need to have a predictable and reproducible tumor growth rate to generate reliable and reproducible animal models. Also, the time between you implant your tumor into the animal and you are able to confirm your tumor by, for example, MRI, this time duration should be minimized so you can generate a practically feasible animal model that you can work with in the laboratory. Also, to evaluate treatments, it's important that the length of the survival duration of your animal models is of sufficient length. So it means that the tumor growth can't overrule the animal in such a fast time that you can't even evaluate if your treatment works or not. Next, ideally, you have a syngeneic host that is non or weakly immunogenic. And at last, we do not want the development of extraaxial tumors or extracranial tumors in the animal model, as this is something that we don't see in human situations. So the translatability of this model will be reduced if we see those tumors. And just to clarify, extraaxial tumors are defined by tumor cells that invade through the cranial sutures, and extracranial tumors we define by tumor cells that proliferate on top of the skull. And just as a disclaimer, I want to say that even though we see progress in advanced techniques or animal models or cell lines, of course, no animal brain tumor model can fully capture the complexity of the human glioblastoma, unfortunately. Maybe one day the time will come. Now, in this presentation, I will talk about the F98 Fisher rat model, as I said. So the rat model is actually established by a single injection of a nitrosal compound in an adult rat that is 20 days pregnant. What happens then is that the litter develops the tumors, which by histology was confirmed to have the characteristics of human glioblastoma. This is a cell line that's been developed and is also commercially available. And this is also how we then generate this model. We buy the cell line, we grow the glioblastoma F98 cells, and then we can, by using a stereotactic frame, inject the cells into the animal model, which is a Fisher F344 syngeneic host for the F98 cell line. When we evaluate them using MRI and histology, we actually see the characteristics of human glioblastoma. So first of all, we use an animal model that's immunocompetent, which is very well. Next, we see a heterogeneous group with an invasive growth pattern and permeability of blood-brain barrier. And this is something that we visualize here, for example, using a contrast-enhanced T1-weighted MRI, where you see the glioblastoma lighting up due to the permeable BBB. On the MRI, as well as on the histology, we see a necrotic core, we see neovascular proliferation, and when we evaluate, for example, with PCR or qPCR, we see also that the tumor microenvironment is quite consistently similar as human is in a human. We see, for example, microglia, reactive astrocytes, gap junctions, and this all contributes to therapy resistance, and this is something that's also being observed in this animal model. So what is there in this animal model in terms of criteria, and what do we still miss? So we do see that it mimics a human glioblastoma. It does have a predictable, reproducible tumor growth rate, but I have to mention that this depends on the amount of cells that are injected. Also, the time interval between tumor implantation and tumor confirmation in previous research is minimized, but also depending on cells inoculated. We do use a syngeneic host, a Fisher rat, that's non or very mild weakly immunogenic. What we do miss is these 2 points that are actually interlinked between each other. So we see that extraaxial tumors and extracranial tumors do develop in this model. And this, of course, impacts the length and of the survival of the model, and thus how long we can evaluate treatment. We do think that these extraaxial and extracranial tumors are developed, and this is likely attributed to the reflux of the tumor cell suspension through the injection route. I also want to stress here that this is something that we also see in other animal models for glioblastoma. So, for example, the C6 or the 9L animal models for glioblastoma, but this is something that stays unmentioned or unresolved between studies or publications. So just to visualize the problems to you is that, for example, here you see the glioblastoma on the contrast enhanced MRI, and here already extraaxial tumor, and this is at tumor confirmation. So this is day 0. This day is defined as the first day that we can say the tumor is large enough and visible on MRI, so we can start giving treatments to the animals. So from the very start, we see the development of extraaxial tumors, and later on, for example, 18 days post tumor confirmation day, we see a huge cranial tumor as well as here, and this extraaxial tumor develops and makes the distinguishment between glioblastoma and extraaxial tumor very difficult, which makes analysis also almost impossible. So what does this mean? First, we see that we see a decrease in animal welfare, and this is in respect of the 3 R's. So the 3 R's are at, the guiding principles for more ethical use of animals in research and stand for replacement, reduction, and refinement. So the more your animal welfare is decreased, the more faster you reach your human endpoints, the faster you have to euthanize your animal, and thus the more animals you will need to reach your sample size for your research question. Of course, as I mentioned, this reduces your reproducibility and also translatability of your animal models, because this is something that's rarely seen in human glioblastoma. Because, as I said, you have usually you have to euthanize your animal before they reach their human endpoints based on the glioblastoma tumor. This prevents meaningful survival analysis and thus hinders the exploration of adjuvant therapies or just new therapies in general. So now I will talk about the workflow of our optimized animal model. So the most important thing here is that you can keep improving an animal model, but it has to keep the balance between what is clinically relevant and also practically feasible for yourself as a researcher, but also for the animal itself. And this is something that we took into account in this workflow. So here is a general scheme overview of this workflow. So we first, of course, grow the F98 cells in culture and then inject them into the Fisher rat by using a stereotactic frame. After a certain amount of time, we confirm the tumor by contrast-enhanced T1-weighted MRI, and this is what we call the tumor confirmation day and define it by day 0. After this, we start the standard of treatment, and I will explain this more in detail in the next slide. But we try to mimic the human situation as close as possible. So we will give radiotherapy and chemotherapy going from radiotherapy here in this case, from day 1 to day 5 in fractions. And this is a first change already in this animal model. So as in humans, fractionated radiotherapy is given, and here we will give, well, hypofractionated to keep the balance between practical feasibility, of course, possible. And this we have determined in 3 fractions of 9 gray. I will come back to this later, but this is given on day 1, 3, and 5, so every time with 1 day in between. Then the chemotherapy is given concomitantly from day 1 to 5, and after that we follow up the tumor growth every 3 days by again using contrast-enhanced T1-weighted MRI every 3 days until the humane endpoints are reached. So the first solution that we incorporated in this animal model to reduce these extraaxial and extracranial tumors lies in the inoculation process. As we hypothesized, this is the main cause of this backflow. So first of all, we varied the amount of cells that we inoculated. In our research group, we already saw that if we inoculate 20,000 cells in 5 microliters, these extraaxial and extracranial tumors develop, and these were the pictures, the images I showed you, the MRI images I showed you on the previous slide. Also, we know from other publications that at least 100 cells are needed to guarantee tumor development, and that's why we decided to range our cells going from hundreds to 500 to 1,000, and then 5,000, 10,000, and 20,000. So we generated 5 groups. After this, we improved the inoculation process itself. So what we did is we first created a cavity. So this means that when you go with your needle to the location where you want to implant your tumor, we go actually 2 millimeters deeper. This is because usually a drop is between 1 and 2 millimeters long. So you create actually a cavity in the brain tissue, and this minimizes your pressure around your needle and ensures that the injected cells are not, or at least when you inject the cells, they remain in place and will not be pushed back along the needle track. So when after this cavity, you can already inject your droplet, your cell suspension with the F98 cells, and we go back with 2 millimeters again. This is actually to allow all the remaining cell suspension that's on your needle to fall back or settle in the cavity, and so prevent being pulled back with the needle along the needle track. So after this, we incorporated a waiting step of 5 minutes, and this is something that other publications already show, but they use a range of seconds. They actually show that when you wait for 10 seconds, 15 seconds, you already reduce this backflow of cell suspension along the needle track. But 10 seconds is not enough, and this is also something that we saw in our research group. So we increased this by 2 minutes range. So we use now 5 minutes, and afterwards a very careful needle withdrawal in 6 steps of 7 millimeters. We do so each step. We wait 2 minutes again, so the cell suspension can settle, prevent it to being drawn back along the needle track, and in this way we hope that this multi-waiting step is crucial, and we actually see that this is crucial to reduce the extraaxial and extracranial tumor formations. So this is about the inoculation process. Now the treatment process is done to increase the translatability of the animal model. So as I mentioned, we use a fractionated or hypofractionated radiotherapy scheme of 3 fractions of 9 gray. So this is some biologically equivalent dose to the 30 fractions of 2 gray that is given to humans. Also, we will irradiate the glioblastoma, not the whole brain will be irradiated, but we want to minimize the exposure to the healthy brain tissue. And this is done by using one static beam that is first parallel, here you can see this, parallel to and following the inoculation route. This is, of course, to potential single cells that are still left along the needle track, so we can irradiate those single cells and again minimize the extraaxial and extracranial tumor formations. Next, we use 3 non-coplanar arc beams. So one is this static beam, and the next, this is accompanied by 2 non-coplanar arcs that can rotate around the animal, and in this way deliver very precisely the 9 gray of radiotherapy to the tumor, as is highlighted here, and minimize the risk to the healthy brain tissue, which will improve and your translatability of your animal model, also the welfare, and thus also the survival length of this animal model. So the main results, I will show you in the next slides more detailed, but there is a main message here. You can find more details, obviously, in the publication here on the right side. But the main message is that if you decrease the amount of cells, if you inject lower amount of cells, we see an increase in variability in your animal model. And this, of course, means you decrease your reliability and reproducibility of your animal model. On the other hand, if you increase more cells, you increase these malformations that we call extraaxial and extracranial tumors, and this decreases your translatability of your animal. So to zoom into the first result is decreasing the amount of cells. So on the left figure, we see the time in days, so time from when we inoculate the cells into the animal model until we can confirm the tumor growth on MRI. And on the x-axis, you see the different groups, so the different range of cells. And we see actually that the less cells are injected, the more time, obviously, it takes until the tumor is established, but also the variability increases. So we see in less than 5,000 cell groups, we see a high variability, and this decreases when we inject more cells, and this is quite comparable variability from 5,000 cells on. So when we divide the cells, for example, by 40, going from 20,000 to 5,000, we see an increase in days until tumor confirmation multiplied by 3, and also variability multiplied by 3. If we then look on the right, which shows a figure of glioblastoma tumor volume in function of days post-inoculation. So day 0 is here the day of tumor confirmation by MRI. We see that in the cell groups lower than 5,000 cells, we see more variability within each group, so more variability between individual animals in each group, and thus less uniform glioblastoma growth, which all contributes to this decreased reliability and reproducibility of your animal model. If we then look to the other side, so when we increase the amount of cells, we see on the left figure is the amount, the percentage of animals that develop an extracranial tumor, so the tumor cells growing on top of the skull. And we see that if in the groups below 5,000 cells and below that, there is no development of extracranial tumors. The higher cells are injected, we see that 33 to almost 50% of animals develop an extracranial tumor. On the right side, we see the probability of an extraaxial tumor. So what is the chance that an extraaxial tumor will appear depending on the number of cells over time? And here we see that the higher the amount of cells, the higher this risk is. And this is, of course, both of them are coupled with the survival. We see this, that in the groups of 500,000 and 5,000 cells, the survival rates of these animals are larger, which can make or confirms our hypothesis that both these malformations contribute to a lower survival of the animal. At last, to increase the translatability of the model, we used the hypofractionated radiotherapy scheme. And based on the previous figures, we found that actually inoculating 5,000 cells in a 5 microliter cell suspension keeps or generates the optimal balance between the reliability, reproducibility, and translatability. So we keep the variability between animals low, and translatability based on malformations also low. So these amount of cells proved to be the most standardized cell amount that proved to show the best results. And so this example here, the MRI images and the glioblastoma tumor volume growth is the ones that are with 5,000 cells or the animals injected with 5,000 cells. And what we see is actually that so day 0 is again tumor confirmation day, we see that the tumor volume is quite stable up until day 18, and afterwards we see an exponential increase of tumor growth, and this is something that's kind of confirms what's happening in the human situation, namely that radiotherapy and chemotherapy do their job, but they have limitations. And that's why new effective adjuvant or not adjuvant therapies are needed for this tumor.
Vivi, I'm sorry. You have 1-2 minutes. If you can wrap up, I'm loving it, but
Yes,
we need
yes.
to move
Oh,
on.
of course. Okay, well, very quickly then, an example case here is tonabersat. Okay, as an adjuvant therapy, I will skip the thing there, but what we did here is, of course, using the same workflow, but adding tonabersat as a new adjuvant therapy. And I just wanted to show you that when we look at tumor volumes and survival, we do see that adding this therapy improves or extends the survival of these animals. And also in MRI, you can see that control animals, which are shown in green, have actually a higher slope or a steeper slope in tumor volume growth compared to the ones that use this new adjuvant therapy in combination with standard therapy. So just as an example of using this optimized animal model, it does show good results. So take-home messages here is that precision and patience is very important, the gold standard actually, and it generates reproducible and reliable models. Decreasing the amount of cells in this model creates more variability. Increasing the amount of variables, more malformations. So gold balance is here the 5,000 cells. Also, the hyperfractionated radiotherapy scheme is clinically relevant and experimentally manageable for the researcher and the animal. And unfortunately, I couldn't go into details, but you can always read it also in the publication. This workflow is usable for testing new adjuvant therapies. So thank you all very much. And of course, thank you to my team.
Thank you, Vivi. It was amazing. We'll leave the questions for the end of the session. So I pass it on to Nuria.
Thank you, Rui. So next speaker is Paula Candiota from the Autonomous University of Barcelona, and she's going to talk about MRSI-monitored chemo immunotherapy in mouse glioblastoma. Thanks, Paula.
Thank you, Nuria, for this introduction. So I will just share the screen. And let's see if it works. Yes? Is it okay?
Yes. It's fine.
Perfect. Thank you. So yes, thank you, Nuria, for this introduction. So I will just go through our experience in MRSI monitoring chemo and immunotherapy in this mouse GBM, which is only one. First of all, before entering that, I would like to bring what I think it's a bit of elephant in the room, because it's quite challenging to compare ourselves between different murine models, dosage, chemotherapeutic schemes, and age equivalences that are so different between us. And I think that we should talk about that. And then I will go through our experience and what we learned about the cancer immune cycle, and some just two minor things of the future of translation. I think we touched several things that I also think that all of us want or aim for future translation. So let's go on. I have been just looking around this fine and recent review, delve into different murine models, just exploring the advantages and disadvantages of everyone. For example, genetic engineering mice that are nice because they replicate nicely the start of the pathology, but they are hardly reproducible. They are not scalable, so very difficult to handle. And the humanized models that are receiving increasing attention, but they are costly. I think they are hard to generate and maintain, and it's described that they do not really capture all human immune system, although maybe this is for the moment the best model. And at GEC261, this is the model I will talk more about, because we use essentially this model, which is easy to generate, is replicable, reproducible, but on the other side, it has an excessive mutational load in comparison with human glioblastoma. I think this goes something that Vivi told, that there is no ideal model. It depends on the question you have, depends on several things, but each one of the models seems to have handicaps and advantages. One thing that as a reflection that I also do by myself, are we taking into account the equivalence between human and murine? This consistently reported in our studies, because there are ways to do it. One disclaimer is that, as we were told, so in our case, we are not really doing the Stuck protocol, and I think it's quite difficult to replicate in mouse. But let's talk about, chemotherapy, to name one. So a fast search in literature just focusing in GL261 and temozolomide therapy, which is our therapy. Just to make it simple, randomly chosen papers, not so random because 2 of them are from us, from GliMR, but the doses are quite different, seems to have some consensus around 50 or 60 milligram kilo, but the doses can vary from 1 to 130. And when you try to translate it to human, some of them are equivalent to adjuvant, but some of them are lower, some of them are higher, and the schedule is totally different between publications, making it really hard to compare ourselves with the others. Regarding the age, this is another issue, because glioblastomas are diagnosed in advanced ages. So the ideal mice model would be 90 weeks of age, which of course we are not using it. We are using younger models, and then this is described to have more optimistic responses, because older mice would have a more immunosuppressive environment. And then the same 6 paper, let's go through, and it's true that most papers use between 7, 8, 9 weeks, and this is adolescents when they align human and in mirroring ages. This is another factor that vary a lot, as well as the tools for following the evolution of the tumor. It's more hard to fix because not everyone has an MRI, not everyone has access to it, so many ones using bioluminescence and people not using anything at all, which is really difficult to imagine. And then, so let's go from our side, our experience in magnetic resonance approaches for non-invasive assessment of therapy response, mostly chemotherapy, and a minor part of immunotherapy. So almost all that I'm showing is built over the GL261 glioblastoma model, which is not the topic, immunocompetent, already mentioned it. We have already mentioned the advantages and disadvantages of this model. For me, one of the advantages that I did not say before is that there is a lot of literature. So you can read about what others have done, while some models are hardly described. So I think it's one of the advantages of GL261 is that it is very well documented on literature, and as far as it's important. Our data is acquired at 7 Tesla, and the most of the data I will show again is GL261 model treated mostly with temozolomide and immunotherapy anti-PD-1, and it's based on basic T2-weighted MRI to inspect tumor volume and inspect tumor appearance and evolution, and MRSI magnetic resonance spectroscopy imaging with protocols well defined within the group, which are based in short echo time acquisitions. I'll try to explain a bit better later, because the classification system that we developed is focused on short echo time data. That's why, in addition to MRI, which is an anatomic or sometimes physiological information that we can obtain, magnetic resonance can also give us biochemical information, metabolic information from this environment, provided we suppress the water signal, which is too intense, so we can see the rest of the metabolic profile. And this could be done. Oh, I did not do the pointer. Let's see, sorry. In a single volume like this one, or multi-volume like this one, in which we combine metabolic and spatial information. There is one thing that the acquisition, quantitation, and processing of this type of data is challenging, because it requires from you a different knowledge, different from the ones that you need to acquire and interpret MRI. And people are not really used to it. So, moreover, most of the papers reporting MRS or MRSI sometimes focus on 1, 2, or a few metabolites, disregarding the rest of the rich pattern. That's why our group tries to look at the whole pattern, to try to understand the rich information which is contained in the spectroscopic data. Then the idea is we want to follow treatment and to detect response, so we have to start from some place. So our group developed a machine learning approach for this classification. I am not the developer, I'm a user, so I will explain very briefly, which is beyond of the object of this talk, to explain the whole classification system. But of course, you have to start from something. So a control untreated and a treated group with temozolomide, and this group is followed up, so we can check the volumes, and we can also make histopathological confirmation and acquire the data. And acquire the data to train a system. To train a system with the best information we can. So we select voxels, volumes of intercept reflecting real zones of the tumor, untreated or treated, and the normal unaffected zone, avoiding edges or peritumoral zones that could have low quality or mixed information that could just introduce some noise or confusion. And our system, this type of approach that I will not go into detail, it's well described, is able to extract the main information, the main spectral information, paradigmatic spectra or sources representing each condition, each pure spectra of a very, very well-selected group of control and treated responding mice. So now you have the three sources that I will refer then as sources from now on. Sources that represent the spectrum characteristics of each situation. So with a new case, so the system keeps your case, compare with the fixed sources, decide the highest correlation. Each source has a color. So now you can generate what we call the nosological image, in which now each voxel has no longer a metabolic spectra pattern. So now it has a color, which defines the source to which it demonstrated the highest correlation. This is the nosological image, that's it. So I will refer it now from nosological image when I say nosological image is this type of generation. This spectra had differences, very, very subtle, but imagine that this is not a single spectra, it's not a range of spectra, it's the source capturing the main characteristics. But we will talk about these differences later. They seem tiny, but they have a meaning. And then we can do longitudinal explorations, right? So, and the same at the initial phases, when tumor is already treated, but it's not responding. So the red, which is the control color, untreated, unresponsive, appears. The green color is associated to patterns shown by responding tumors. So here, even before the tumor enters in growth arrest, the system was already able to detect the green color associated to the response. That means was an earlier information. And it also happens here. So the first stages do not show response. Here, tumors still keep growing and we see response. So tumor fastly respond. And when it relapses, it fades again, showing the control unresponsive pattern. But we know, Nuria will recognize this figure. We know that glioblastomas are heterogeneous, are large. So this is a work from Nuria, from her PhD thesis. So we went from acquiring only one slice and nosological image to cover the whole tumor extension. And now she had no longer one, but 4 nosological images, and also stated a tumor responding index. What is? To count pixels in tumor. Green pixels and the total of pixels, and establish a percentage. So we thought at that moment that the high TRI, tumor responding index, that means the percentage of green responding pixels, would mean a high therapy response. But in a longitudinal exploration, when the tumor was in growth arrest, this black line is the tumor growth volume. Sorry, this is in growth arrest. And so she acquired several times this multi-slice nosological image and calculated the TRI. So what we would expect here, we would expect that it would show green the whole time, right? But it did not happen. It had different thing happen, in which this TRI, which is the calculation I have shown just before, oscillated with a frequency of 5 or 6 days. So yeah, that was really surprising because we were expecting the whole green thing. and it did not happen. So the hypothesis that maybe thinking about what happens every 5, 6, 7 days. So the cancer immune cycle could be an explanation. And this was already described by others, that the immune cycle, host immune system was important in therapeutic treatment of cancer. So let's take a look in histopathology to see if this makes sense or no. And so the histopathology shown the increase in IBA1 stainings from microglia macrophages and also an increase in CD3 lymphocytes. So let's just go back and check if this is true, if this is happening. Here we have an amplification phase, something, a proliferation. Here these immune cells are proliferating. And so it would be very intelligent and smart to not applicate any anti-proliferative therapy here, just to spare this phase, right? And that brings us to the immune-enhanced metronomic schedules that as we named our administration schedule. So if this was true, so we should just respect this cancer immune cycle, and this was already described by others. So we just join pieces of information and our guessings and state the immune-enhanced metronomic schedules in which temozolomide is now administered every 6 days, sparing the proliferation phase of the cancer immune cycle. And this was surprisingly good, because we have even cured mice that once cured, let's see if the immune system has something to do with this. Let's just try to rechallenge. That means try to generate the tumor again, and let's see what happens. The first thing is that the oscillation on that tumor responding index that we already saw in the past repeated. So this was important. Maybe it's not a matter that we have green all the time, that we had, rather than this, that we had the correct oscillations. So the cured mice that were rechallenged, that means trying to generate the tumors again, showed immune memory. So this is empirical information telling us that the immune system has everything to do with this. And we gain an advantage applying this immune-enhanced metronomic scale of every 6 days. So the hypothesis is that the nosological image is changing because something in the microenvironment is happening related to the immune system of the host, in this case, our mouse. So let's validate it. So we tried to get samples from control and transient responding mice and validate it through different techniques. Yeah, of course, if I euthanize a mice, I will not know if it would be cured or relapsing or whatever. But this is the price of the validation. And then we detected that this is qPCR, so expression level, that in agreement with IBA1 immunohistochemistry, F480 was increased in responding sample, and also the ratio of M1, M2 macrophages, which M1 is the antitumoral and M2 is protumoral macrophages. This ratio passed to a switch in the responding samples with a higher percentage of M1 macrophages. Important. PD-L1, which is an immunotherapeutic axis, PD-1, PD-L1, it's also increased in responding samples in agreement with the M1, M2 ratio. So, these things were strictly related to microenvironment and host immune system. So something is really happening in these samples, also increasing lymphocytes, CD8 and CD4. And in joint with a German group, we have also analyzed metalloproteases expression that also increased in our treated responding samples. So, okay, we have to go back to these changes and try to imagine that we are having information of not only the tumor cells, but we also have the macrophages that can represent up to 40 or 50% of the tumor mass, which is very relevant when contributing to this pattern, and also these giant multinucleated cells that appeared during treatment, during the response, transient response. So if we look at the mobile lipids or lactate, so we could try to guess what's happening. So in tumor cells, they are replicating less. They have what we are looking to these signals together, because at 1.3 ppm, the signals overlap. But we can also have a look on this one. It's only lactate. So it's a joint contribution. So tumor cells, so less replication, less lower lipid droplets, while the multinucleated cells have increased glycolytic rate, increased lactate, but less lipid droplet turnover. M1 are more glycolytic macrophages in comparison with M2. So the joint result seems to be that the joint signal shows less intensity, but lactate is somewhat increasing overall. And what about alanine? So yes, less glycolytic rate, less pyruvate to be converted to alanine. And M1 relies more on glycolysis, but prioritize lactate synthesis, which agrees with the previous slide. The multinucleated cells has less transamination, no active protein synthesis. They are really quiescent. So this could explain why the alanine signal decreases. The PUFAs, we think they are mostly related to apoptosis of tumor cells. Macrophages are not probably contributing. Multinucleated cells can also store lipids, stress adaptation, so we can guess how each of these parts are contributing to the whole pattern, and we will try to peel this off during the next year. And we can do the thing the other way around.
Ana Paula, sorry, it's like 2 minutes. It's fine.
Okay. Yes, that's super fine. This glutamate or glutamine increases in tumor because tumor cells are demanding for glutamine for carbon and nitrogen sources, increase in nucleotide synthesis, and glutamine accumulates more in M2 macrophages, increases glutamine synthesis. So I think we are just seeing a joint contribution of everyone, every piece of this tumor microenvironment. And the hot question is if we could also spot response in anti-PD-1 immunotherapy, and the answer is yes, both in single immunotherapy or combination therapy with temozolomide. And the hot question was, what about immune memory? So we was seen also in anti-PD-1 monotherapy, so showing from one side that this approach, MRSI-based, is also able to detect response in immunotherapy and also combination therapy, but the combination therapy had a very fast result of curing animals, and I think we did not have time to mount the correct immune response. So I would just go through super fast towards different models. So I was really interested in Vivi talk because she talked about the extracranial tumors. So we are now trying the CT2A, which is a different model, less mutated, with less mutations than the GL261. This is one characteristic. We cannot control that. They grow in extracranial. So I'm happy that I'm not alone. And just that our classifier was able to detect either tumors in CT2A and also the very poor response to temozolomide that they have. So the classifier detected is a poor response, intermediate to low response, and the patterns were as expected, the normal, the responding, and the control. The patterns, the metabolic pattern agrees, which is expected. So the classifier is robust. I'm not talking about SB28 because this is not ready yet, and it is not so good as this one. And I think, let's just finish, Nuria, don't worry. I think the future passes to a joint classifier in which MRI is trained with MRSI information, because I think it will be very difficult to convince clinicians that they should do MRSI or MRS, and they do not really know what to do with this. And I think this is the future. The translation passes for these two steps. And I would like to thank the wonderful people that performed the PhD in the group. So it's all their work, not mine. And the funders, and we're happy to take questions with Vivi.
Thank you for the
I can
amazing
stop sharing if you want.
talks. Sure.
That's it.
So the floor is open for questions. I see Harish has a comment here and to questions. Harish, feel free to speak if you want. I can also read what you posted here. So great talks from Vivian and Paula. Despite the various issues with repeatability of the model and treatment regimens, there seems to be some convergence, at least with regards to the F98 rat and the GL261 mouse model. However, both are syngeneic models. Do we have similar data on a PDX model, that's a patient-derived xenograft model, where MR has been used extensively, or at least, well, more than one paper? Do you have any information on that? I don't know, Vivi, for instance?
So I know that in the last couple of, let's say, 5 years, I think from 2020 on, there is more research done on PDX models. But before that, no. So of course, in 5 years and taking the corona in it as well, not a lot of papers have been published. However, I do know that, for example, in my research group, there is a PhD student now doing experiments with PDX and also using the optimized radiotherapy scheme that I now just had a talk to, and will do MRI as follow-up longitudinally, evaluating different drug repurposed treatments. So there is something coming up, but not now. The only thing I know from his research is that there is a lot of variability even in the cell lines. Also going from, you have to be very careful with the replication and how many times you can, in your cell replicate it, and this creates a lot of variability as well that you also take into your experiment once you measure with MRI, for example. But I don't know if you and Paula have more insights as well.
No, not. I'm trying to fastly make a mental Google, but I'm not remembering. So there's a lot of things. Sometimes I think that people just prefer to go to bioluminescence or a type of things. From my knowledge, no, but it does not mean that it does not exist, only that I don't know.
And my second question was, do you know if there is a syngeneic model of IDH mutant gliomas?
A great question. It's the second person that asked it to me a few times. No, our lines are not IDH mutant. And I have searching quickly and I did not find anyone. In fact, for the new WHO classification, they are not even glioblastoma. So maybe, I don't know if it would be feasible to modify a cell line and try to introduce this mutation artificially. Do you know some, Vivi?
No, unfortunately, I don't have more information than you on this. Yeah, I agree with you, actually.
I know that our lines are not. So this is for sure.
Yeah.
So both I don't know, Harish, if you had any more comments on this or would like to follow up.
Oh, but if I had the answers, I wouldn't be asking those questions, would I? But yes, there is an IDH mutant cell line, but that's a human IDH mutant. That is from I think the group from UCSF. Sabrina Ronan has published a couple of papers on that, and their group has been doing that. But speaking to that group before, it has the same exact problems that you mentioned, Vivi, before. Not only the PDX models are hard to grow, but their predictability is even less. And so they were talking about it can take anywhere from 2 months to 6 or 8 months to have the tumors to grow, even in an immune deficient mouse. So only if somebody is actually growing them as their own biological study with a huge budget at hand, that's possible. But for smaller labs, the costs just become prohibitive. And that's why
Very
my
much
question
agree.
was that is there a syngeneic model? Then obviously that will reduce the time.
Yeah, yeah.
Maybe an
Absolutely.
intermediate thing. Just was thinking out of. I don't know if we or Nuria remember that Magda have tried to generate a transplantable cell that originate in a gem. If this gem was the IDH mutant, which I don't really know, but imagine if it would, making a transplantable line could not solve 100% this problem, but could be maybe an intermediate solution. Maybe. But they had this problem that you mentioned, Harris. She had this problem because some animals grow super fast and the others maybe took months.
Yeah.
Super variable. Yeah, I remember that.
So we had two very comprehensive talks here, both from Vivi and then Paula. We are beyond our time. I cannot help myself when asking about, I mean, you spoke about chemo radiation and chemo immunotherapy. How about the resection part? That's very difficult to perform in animals with a high mortality associated usually, but it's also a standard of care. Could you both comment quickly on that? What's your take and what the future should be for animal models?
And I can start. So yeah, this was always on the way. So we always wrote several times that we wanted to do it, and there is even a Jove Journal of Visual Experiments journal with someone that making a surgery. But the first thing that we should do an implantation in different, more cortex place to do it more easy. We did not do. But I totally agree that this is part of the standard of care, and now I am jealous of the equipment of radiation from Vivi.
Maybe a very quick question, quick comment. I agree, but the only thing maybe that I would want to change in my rat model, for example, because you say indeed radiotherapy is more optimized, but what we do now is giving only concomitantly temozolomide in the animal model and not adjuvantly afterwards. So this is something that also should be taken up, in my opinion, in animal models to also mimic that part, because as we know, temozolomide is radiosensitive and it takes a while until it gets activated, let's say. And this is something, in my opinion, that's still missing, for example, in my model.
Okay. Nuria, do you want to wrap it up?
We've had time. I have some, because I have experience working in the model with rat and mice. And I'm not so fortunate to have the injector adapted to the stereotactic frame. So we have to deliver the sensor very, very gently, so to speak. But I don't know if my question is for Vivi. If when you perform your experiments, your treatment experiments, when did you start? I mean, then you pass very, very fast in the last part. It's in the same day. I mean, all your rats have more or less the same tumor volume a day. I don't know, whatever, whenever you can start the treatment, or there are other kind of variation.
Do you mean with the new therapeutic or also with the standard of care?
With everything, the standard of care. Yes, I mean, you have to decide one day to start.
Yes, exactly. So what we decided is once we reached a volume of, well, we actually looked to make it easier in diameters on the MRI. Once the tumor reached 3 millimeters in diameter, we considered this large enough to start a treatment the next day. So once we confirm it, we start radiotherapy and chemotherapy the next day. And we determined the 3 millimeters because we actually saw in previous experiments when the tumor is smaller than this, then you actually irradiate all your cells, and then you get a compounding factor of your radiotherapy that, of course, you want to avoid. We are not treating the glioblastoma with radiotherapy. We know this also from clinical practice. but it slows down the progression, let's say. And this is why we chose the 3 millimeters. For example, for the new adjuvant therapy, it all depends on your knowledge of your therapeutic that you're testing.
But it's the diameter you
Yes,
said. Okay,
exactly.
but my question is, all the rats that you implant, I don't know, this date has the 3 millimeter diameter the same day. I mean, it's
Well,
very reproducible in that
yes,
point.
I work in batches, so I inoculate, for example, 8 to 10 animals per day. I know it takes around 10 days until you can confirm your tumor. So I divide my animals in different series because it's impossible. Also,
Yes, but I mean, all your imagine 6 or 8 rats you implant, the 6 or 8 rats start the therapy the same day because they have
Yes,
this kind.
yes,
Okay, so
exactly.
it's very reproducible.
Yes, exactly. It's all these animals start on the same day radiotherapy, and that's why I divided by in series of animals, of course, so we can reproduce this in each animal. So there is no animal that, for example, we confirm the day and the tumor, and then only 3 days later we start the treatment. No.
I mean, I really like your protocol. Maybe I have to write you an email later, but and I was also supposed to think about the difference because Paula told this mice that the tumor escapes outside. I know they do all the protocol very good as well. So it's surprising. It's the rat, it's the place, it's the animal model. I don't know if Paula, what do you think about this?
The only thing that I know that everyone that I ask about CT2A tells the same.
Okay.
So it's impossible.
So it's a kind of cell type
We
thing.
have tried that dental cement, and in principle it did not work. So we have to keep trying. And the GGL261 does not do it, so I don't understand.
You can also clean the surface after you inject.
I
Some
do
groups
that.
here are doing it. We will be kicked out very soon by the SMRMB office.
I think
Christina
there is
may
a
want to
question in
kill
the
us.
chat.
There is a question that I would like to
Yes.
ask because my Rui, who is Portuguese too. So, have you tried to apply ultrasound-induced blood-brain barrier opening with your animals, with your animal models, and check the readout? Maybe Ana Paula this time, and then Vivi quickly.
Yes, no, because the BBB is already damaged. So what we have been in a project that would try this, but we were not granted. So no, the short answer is no, and the large answer is that they really don't need this model.
Vivi?
Yes, very quickly. Yes, there is actually in our research group a study going on that's actually investigating this, but not to induce BBB opening, but in terms of the tumor is established. So we see that the BBB is permeable on the MRI, but to open it more. So, for example, antibodies, monoclonal antibodies can enter as a new therapeutic. And this is an ongoing study, so I can't say a lot about it yet, but we do see promising results. For a very short time, the BB is being opened shortly, and it's also reversible, which is the interesting thing in the ultrasound setting.
Excellent. Well, thank you, both our speakers and everyone for attending this session. We're 10 minutes past the time already, so thank you for staying. And yeah, we'll see you for the next
events.
webinar.
Thank you.
Thank you.
Bye. Thank you.